Thanks, Dr. Dinesh and AOS for the opportunity. I'll be speaking on FFA and posterior uveitis. Posterior uveitis, as we all know, consists of basically the retinitis, choroiditis, and the vasculitis part. So there are features there which you should know about FFA so that you don't miss these findings, and they are very easy if you look at these findings. What FFA does is basically it differentiates, helps us to differentiate active from inactive. The first thing it does. Second thing is nothing great. It just shows us the morphological pattern which is seen clinically also, but it delineates better because in black and white the things are better. Third is it tells us about the secondary changes because of the inflammation. There is a leakage there. There is macular edema, capillary non-filtration, whatever occurs secondarily to retinitis and vasculitis. So active versus inactive, as I've already said, we want to differentiate whether the disease here is active or inactive. So there are only two things in posterior uveitis, hypo to hyper. This you have to remember. In active lesions, first you will see hypo, you will see black, and then it will turn white in front of your eyes over next 12 minutes. And then there is a hyper there initially, which becomes less hyper, or what we call it a window defect or a transmission defect. That means something hyper initially means it's not active. It is taking up the stain and it is not active. So what you have to see clearly is clinically also you can make out there is a fuzzy edge in case of a choroiditis of a patient of serpiginous choroiditis. And if you correlate early findings with the late findings, you can make out the early this edge is black and this edge is suddenly lit up in the late phases. This is how you differentiate between an active lesion. Whereas you go back and see the lesion which is behind that, this is basically a lesion which is scarred, which is very well delineated, not blurred. And if you see the hyper initially and later on it remains hyper, more hyper, doesn't matter, but this hypo is turning into hyper is the clue here that we are seeing an active lesion which is collaborating with the clinical findings there. Similarly, this eye is also full of findings. You have active edges, you have inactive edges. If you clearly see these edges, they are hypo. They are hypo in the initial frames, in the early frames within first 1 minute, and then they all become hyper in the late phases. And this is the clue here. This is nothing great. You cannot miss these findings if you clearly see. All serpiginous choroiditis, white dot syndromes, PIC, everything basically is hypo to hyper. So you don't miss an early frame, you don't miss a late frame. So you have to remember if something becomes hypo to hyper, it's active, it remains hyper to hyper. That means something which has healed there. Okay, so it is hyper initially and later on it is not becoming that much hyper. So it is probably a healed lesion there. Again, there can be mixed variety. Now patient had a healed lesions here in the periphery, but new lesions are appearing here. Clinically, you can make out the blurred margins are there. But on FFA, things are more clear because you are seeing a hypo which is becoming hyper in the later phases. But you are seeing, like in this picture, two lesions. This lesion is example of a hyperactive lesion, a healed lesion. See the healed lesion first. It remains black scar there and it remains like that. Only the edge is staining. But this lesion where we are suspecting activity, it is hypo and later phase it becomes hyper. So that shows that clearly it is a hyper lesion, it is an active lesion there. So again, in case of a VKH, you see hypo to hyper, and so much of hyper there is a pooling of the dye there in the late phases. So hypo to hyper. Sometime in our VKH syndrome, only in VKH syndrome there are some RP changes. Apart from the hypo to hyper, we are seeing early pinpoint hyperfluorescence. These are nothing but the changes in the retina, changes in the RP. Due to the chronic changes in the choroid, the overlying retina also starts showing changes. So the main features are hypo to hyper, but if you see these pinpoint RP changes, they are known in the VKH, so don't worry, they are not something else, they are uveitis only. Similarly, the retinitis, which choroiditis have done, retinitis is again hypo to hyper is the active lesion. If you see early hyper, which is fading, is the healing lesion. The example, this is a toxoplasmosis lesion, clinical diagnosis, headlight in the fog, but you are getting FFA done, you are seeing hypo lesion becoming hyper in the late phases. It's the active lesion. Similarly, another lesion which is retinitis lesion, and this will just tell that hypo to hyper lesion is there. Whether choroid is involved or not, the FFA will not be able to tell. ICG can tell this or OCT can tell this. And then again another retinitis, hypo to hyper is the main problem. Heel lesion with just a pinch of hyper there, the heel lesion with the active lesion. Next is vasculitis. Vasculitis, it's basically the itis word there. So whatever the dye will leak, it will stain the walls there. So it delineates the vasculitis better, the FFA. It will show us the complications like I already said, CME, the occlusion. This kind of a picture can never be missed, but what FFA does is it shows the pictures more clearly, because on clinical photograph you can guess that this area is probably you will see capillary non-perfusion there, but your this thing FFA shows us and proves that the dye is just blocking here. This blockage can be again due to hemorrhage, or this can be due to capillary non-perfusion. So both the components are there in this slide. Of course, Dr. Sangeet said NVE. To a subtle examination, to a carefree examination like NVEs are known in case of vasculitis in the periphery. So we can miss these, but FFA will not miss these if you have taken all the frames. Again, the wide angle photo, this angiography is a tool which is important in vasculitis because you are able to see the peripheral capillary non-perfusion areas. Optic disc, again I've said, if there is a papillitis, the staining will start in the early phase and it will increase in the late phase. This is the only thing. This is not hyper to hyper, this is hyper to more hyper. And as we treat these patients, this hyper will become less, and you will see that this hyper is becoming less later on. Again, this is one such patient where we can, a patient of a choroiditis, somebody thought that probably there is a recurrence occurring here, but as Dr. Dinesh has already shown, there is a hyper lesion which has become more hyper there. So this is nothing but a CSR lesion because of the prolonged use of steroids. There is is not a recurrence of uveitis, but a CSR has come up in this eye. To conclude, new cases of retinitis and choroiditis do need FFA, but there is follow-up also. But you should know that for follow-up of a choroiditis lesion, there is an entity called autofluorescence that is much better than exposing the patient to FFA every 3 months or 6 months just to see whether the patient is responding or not. And of course, for the better documentation of vasculitis, NVEs, and the follow-up and the way the regression they are showing, FFA is important. Thank you for your patient hearing.